Okay, we're going to go ahead and get started. Good morning and welcome to week 6 of our 12-week series on health equity and cardiovascular risk. I'm Jim Werner and I'm filling in for Dr. Rao today. He'll be back next week. Please remember to not include any PHI in presentations or case discussions. So these are the disclosures and they, I think, are the same as in prior weeks. Okay, Dr. Beverly and Dr. Ufholz, we'll turn it over to you. Go ahead.
Thank you. I'll start by introducing myself. Hello, my name is Liz Beverly. I am a professor at Ohio University at the Heritage College of Osteopathic Medicine, and I'm also the co-director of the Ohio University Diabetes Institute. And I'll be presenting today with Dr. Ufholz, and I will have Dr. Ufholz start our didactic on telemedicine and health equity.
Hello, and thanks for the nice introduction, everyone. So our learning objectives for the day are we want to speak with you about how technology can be integrated into clinical medicine and how we can help prepare patients to use this technology, as well as how technology, specifically telemedicine, relates to health equity, as well as a couple of ongoing projects to help address these health equity issues. So the first thing I'd like to do is define what telemedicine is, because it is part of a blanket of related but not identical terms, such as mHealth or eHealth. So for the purpose of this presentation, I'm going to be referring to it as telemedicine, which is pretty similar to what we're doing now. It refers to an interaction where both the patient and the clinician can see one another and hear one another and communicate in real time, which makes it different from things such as MyChart messages or patients viewing a pre-recorded video or a telephone-only phone call with no visual. Telemedicine in that form has been around for a while, but for obvious reasons, it started taking off really in the year 2020. And while it's not currently as prevalent as it was during the height of the pandemic, it's still very popular, especially with certain groups of patients and certain medical professions that don't require physical contact, such as mental health counseling. And I mean, it's pretty obvious why it would be. Patients who have telemedicine appointments tend to like them. In Cleveland, where I'm based, complaining about traffic and parking is a part-time hobby, and the patients enjoy not having to deal with that. And our more vulnerable patients, they don't want to be exposed to COVID. So a telemedicine appointment can be safer. So this slide from the National Center for Health Statistics and the year 2021 gives a bit of a breakdown of who is using telemedicine in the past year. And you can see it's quite a few patients, more women than men, and more seniors than younger age groups, which at first surprised me a bit, but it does make sense when you consider that seniors tend to have a greater proportion of chronic conditions, such as heart disease and diabetes, that can be managed via telemedicine. They're also more vulnerable to COVID and the flu, and some of them can't drive anymore. So telemedicine is very well suited for their needs. Next slide. The research on telemedicine and how effective it is emerging. A lot of it will be things such as comparing an in-person version of the diabetes prevention program to a virtual one, rather than, say, the effectiveness of an in-person clinic visit to a telemedicine visit. And naturally, a lot of research evidence is for some of the older forms of telehealth, such as the asynchronous forms. But what we do have on telemedicine in this form so far indicates it's pretty effective. Sometimes even more effective than usual care for metrics such as A1C, which traditionally are pretty hard to make progress in. And the fact that this can be especially effective in older patients who are more vulnerable is especially encouraging. But that doesn't mean that all patients are able to take equal advantage of it. As you can tell from the slide on the left, there are some distinct racial and ethnic breakdowns on who is more likely to use telemedicine, with some disadvantaged groups such as those who identify as Hispanic or non-Hispanic Black being less able to use telemedicine compared to non-Hispanic whites, or those who identify as American Indian, which would not be expected since they are also a disadvantaged group. So I'd be interested in hearing ideas on why that one is. There's also a breakdown in who uses telemedicine based upon income and based upon education. As you can see, the more disadvantaged patients are less likely to have used telemedicine. And these are the patients who tend to be the most vulnerable to chronic diseases and the flu. So they're the ones who could benefit the most from telemedicine. So I'd like to go over the results of a survey that Dr. Rao and I performed at our clinic in Cleveland, Ohio, a few years back. For this, we were surveying primary care patients who were seniors and who were already present at the clinic to get care for a chronic health condition such as heart disease, diabetes, COPD, etc. We did not collect demographics because this was a fairly quick study, although our clinic mostly serves low-income African-American patients, so that was the majority of the patients who completed this. And because we were trying to manage this around their appointments, we limited ourselves to 10 questions. So we know we missed a few things and we're hoping to address that in later surveys. Next slide. So out of 30 respondents, most of them, although not all, had a device that they believed could be used for telemedicine, and they said they did use it to go on the internet, although few of them had had telemedicine visits in the past. And most of them had only a single device, which was a budget smartphone. And the reason this is relevant is that some telemedicine platforms work better on an iOS-based device like an iPhone. And especially when you're talking about seniors who have problems with mobility and who might have vision problems, a device with a physical keyboard and a larger screen, such as an actual laptop, is better suited for telemedicine. And not many of them had that. Next slide. So all the patients who had devices said they used them for messaging on the internet, but for quite a few of them, that was the only thing they used them for. And when we said messaging on the internet, we used WhatsApp as an example, but it's quite possible that participants interpreted that as text messaging, which isn't really the internet. So it's possible they were using it even less than they stated. no participants were using their phones or their devices to take on tasks that are usually done in person in a digital format. So no online banking, no one has an Amazon account, which, no, how common are Amazon accounts anymore? What's more, that some of the more in-depth and interactive features that would help participants build the skills necessary for a telemedicine appointment, like using email or doing video calls, few of them were doing. And we did find it was statistically significant that people who had a more sophisticated device or who were using these more interactive functions were more likely to have had a telemedicine visit. Next one. And this just breaks it down a little bit further. As you can see, having an iPhone or using email was linked to having had a telemedicine visit. And as is also to be expected, there were a few patients who didn't have a device or use any internet functions, so they were not using telemedicine at all. Next slide. And I will turn this over to Beverly. Oh, sorry, Liz.
Thanks so much, Dr. Ufholz. So from that research that you just presented, and that's coming from an urban region, one of the things that we wanted to point out here is that there are disparities based off of geographic location. And so I am located in the southeastern part of the state, where Athens, Ohio, where Joe Burrow went to high school. And in our part of the state, telemedicine is still used, but it is not the number-one choice. And so anecdotally, a lot of the individuals prefer that in-person contact with their healthcare provider. It also has to do with a lot of the issues that rural regions face. So rural regions have a lot of barriers, including limited access to healthcare. People have to travel long distances for care. So while in Cleveland, you might be stuck in traffic, down where we are, it might take an hour just to get somewhere because you're traveling 60 miles to get to a healthcare facility. Because of this, you also may have delays in if there is an emergency, because there aren't necessarily hospitals that are functioning with emergency departments in the county that you live in. So because of this limited access to care, you are more likely to have negative health outcomes. This also leads to increased expenditures for a lot of the patients in our region, and that also leads to increased healthcare expenditures for the healthcare organization. So we might be thinking, why are there increased costs? Well, there are costs simply for traveling. So the costs and maintenance to the car, gasoline prices, people have to take off work, so there are lost hours with work. And of course, you have to factor in that you maybe need caregivers and childcare costs as well. But even though there are issues that are faced in rural regions with telehealth, telehealth does present an opportunity to address some of the barriers here. So I'm going to present a couple of scenarios to show the benefits of telemedicine in rural regions. Next slide. So there was a study published by Zhang et al. In 2018, and this has to do with the American Heart Association and telestroke networks. So back in 2007, you can see that Medicaid and Medicare began reimbursing for telestroke services. And so one of the things that they looked at in this study is they wanted to see if the uptake, if it increased in rural regions. So telestroke networks, it's low cost, it's effective tools, and it's to improve access to critical stroke care. And again, this is because we won't necessarily have specialty centers in rural regions. So they looked at claims data from 2008 to 2015. And you can see here, with the little bit of data that I did present, that the proportion of ischemic stroke cases in which an individual used telestroke services, it did increase over time. And an interesting thing to point out is the proportions that were higher as they increased were younger, male, and non-Hispanic white. And I also want to point out that there were increases that were statistically significant in rural and super rural patients. Next slide. So you can see here, this is a figure of the data you can see. So from 2008 to 2015, just to see the uptake of the telestroke services by Medicare patients over time. And you can see that there was an increased uptake by rural and super rural. And then the other thing I wanted to highlight is there's a lot of promise with diabetes self-management education and support. So a large proportion of our state is rural or partially rural, and rural communities have less access to diabetes self-management education and support. And approximately it's 62% of rural communities across the US. So there was a study most recently done out of Pittsburgh, and it was a 12-month trial in a federally qualified healthcare center that used telemedicine with certified diabetes educators. And they were looking at their provision of diabetes self-management education and support. And they did that via video conferencing and compared that to usual care. And you can see here, it was a small sample, but of those individuals who were in the arm that used telemedicine with diabetes educators, you can see that 64% of them achieved their self-management goals, and it was improving their dietary intake. So there is promise with different types of cardiovascular health education. There's promise with diabetes. So there is promise with different types of cardiovascular health education. There's promise with diabetes education. We just need more research, and we just need to understand a little bit better how we can increase access for all of our rural communities.
Thank you, Dr. Beverly. Dr. Rao and I recently received some funding from AHRQ to help prepare some of our more vulnerable patients for a telemedicine appointment. Cleveland has quite a few resources available to help patients get online and prepare for appointments like this, but not all patients are aware of them, or there's issues with getting them access to these services. So we have created a telemedicine referral service. The first goal being to increase the telemedicine readiness of older African-American patients with type 2 diabetes. We're going to be recruiting from our clinic, so most of our patients will be African-American, but we will not turn away patients who belong to other ethnicities. And then we also want to evaluate how well this program does, because we're hoping to follow this up with an R01 later that might allow us to expand to groups that need a little bit more intensive care. Next slide, please. So the study procedures, we're going to be recruiting patients who are aged 50 to 70, who have type 2 diabetes and who already have a telemedicine ready device, but have not yet had a successful telemedicine appointment. We picked this age range based on our pilot data, which showed that patients over 70 tended to have they usually strongly preferred in-person appointments, and they were not interested in telemedicine, and they were also the less digitally savvy. So we thought it would take longer than our study time period of 1 year in order to get them ready. That's also why we're looking for patients who already have a device, because getting them a device and a data plan and teaching them the basics from the ground up would be a longer term endeavor. So after these patients have given informed consent, they will be screened for their level of telemedicine readiness. We are going to be asking them about things like, what kind of device do you have? What sort of data plan do you have? Do you know how to turn on the device's camera or to open the apps that you need? And Cleveland has a digital navigators hotline, which is funded by the Cleveland Foundation and run by Ashbury Senior Computer Community Center. We've been in close contact with them, and they are a wonderful partner to work with. We will, the research team and the patient will call the navigators hotline together. And from there, the navigators will refer them to community partners who can provide digital skills training and help them prepare for a telemedicine readiness appointment. The final step is going to be scheduling patients for a diabetes follow-up care appointment about 6 months after this occurs. And our primary outcome will be whether or not the telemedicine appointment took place. Next slide. We're also going to be completing post-study interviews, both with people who did complete a telemedicine appointment to find out how their experience was, what they liked and didn't like about the training, how it met their needs compared to an in-person appointment. We'll also be interviewing people who didn't complete a telemedicine appointment so we can figure out where the sticking points were. And this could include people who completed the training but then didn't have a telemedicine appointment, or people who signed up for the training but then didn't go to begin with. We could get some interesting information from that. And we're hoping to expand to a bigger study afterwards where we might help people who begin with no technological advice, and where we might be able to look at some more physiological outcomes, such as changes in A1C. And that takes us to the end.
Terrific. Thank you both for that presentation. We're going to take questions and comments now, and I'll start off with just a question that I have, just based on my own experience with telehealth. With patients with mobile phones, oftentimes, what I'm finding is sometimes patients are out and about. They're maybe riding in a car, they may be shopping, they may be out on the sidewalk, and there's kind of less, it seems to me, less readiness for a telehealth visit than people who are in their homes with a computer or a laptop or something like that, with a little bit more settled. And sometimes the adequacy of those visits, what I'm able to accomplish, I know, with patients during those visits where they're more ambulatory, more mobile, isn't quite the same as when I'm able to really talk with them when they're more focused. Is there any data on that, or I just want to see if you could shed any light on that?
I don't remember seeing any data on that. Telemedicine appointments usually are not broken down by specific type of device patients have, but we are aware of the patient trying to have an appointment from their car on the freeway problem. So one of the things we've asked our telemedicine readiness training partners to do is to talk to them about things such as have your device charged already, test your internet connection, and do this appointment from a private room in your home or somewhere else where you will have a good connection and, some degree of privacy.
Mm-hmm. Okay, I'm glad to hear that's part of the training that people are receiving. Are there other questions or comments for Dr. Beverly, Dr. Ufholz?
Jim, just a comment about what you just said. We do exclusively telephone visits right now, and we've had similar issues where patients may not be prepared for the visit, or they're, like you said, at the grocery store. So what we've done, and maybe, I don't know if you have like medical assistants or anyone that could assist you in preparing for the phone call, but when that does occur, we, very obviously politely explain to the patient, at the next time that I call you, please make sure that you're at home, just so I can hear you adequately. We really try to emphasize that they should think of this as a usual appointment with their physician, even though I'm not a physician, and that they're home and ready to talk, have their data or whatever, they are going to talk with us. We don't have any like support staff right now that helps us, but I would think at least, based on the study that you guys are completing in Cleveland, I mean, if you have a digital navigator, that sounds awesome. Like they could certainly prepare the patient, for that. But that certainly is a tough thing to kind of navigate when it happens.
Sure, yeah. That's good. Good idea to have an assistant to help to prepare the patient for that visit. Okay, great. Dr. Conklin complimented you about increasing access to care through your study. So that'll be really interesting work. When are you going to start on that, Kelsey?
As soon as possible. We have ordered some study supplies. We're going to be compensating our patients with Amazon gift cards, which that's a little bit of incentive for them to start, and also something where we can say, oh, if you need some help on how to set up an account to use these, our community partners can help you. So as soon as those come in.
Okay, sounds great.
And just a final reminder that our cardio webinar is next Wednesday, and you can register either at cardio.ohio.org or through this QR code. Just a reminder, you can view all present and past clinic recordings on our cardio website. And finally, a post-clinic survey has been emailed to you. You should have gotten in your inbox about 10 minutes ago. I did send out a finalized case study schedule, so please let me know if those dates don't work for you. Otherwise, we're going to move forward with that. And then just let me know if you have any questions or concerns.
Okay, everybody have a good day. Take care.